Welcome to the GBHI Symposium, which is part of the Engaging Dementia Conference. The title of our symposium is Dementia Care in Global Settings. My name is Brian Lawlor. I'm Professor of Old Age Psychiatry at Trinity College Dublin and Deputy Executive Director of the Global Brain Health Institute. The aim of our symposium is to address different aspects of dementia care from across the world. Dementia is truly a global challenge, and we need to learn from one another and share global perspectives about how best to tackle it. In this session, you'll hear about different aspects of dementia care and practice from diverse professional perspectives and countries presented by a range of Atlantic Fellows at GBHI. We hope that by sharing these diverse perspectives, we can help break down the professional silos that are slowing progress in creating a more inclusive and fairer society for people with dementia. Before we start this, let me tell you a little bit about the Global Brain Health Institute. It's dedicated to protecting the world's populations from threats to brain health. It was founded in 2015 by a generous gift from Atlantic Philanthropies, and the founding sites are at University of California, San Francisco and Trinity College, Dublin. The mission of GBHI is to reduce the scale and impact of dementia in three ways: by training and connecting the next generation of leaders in brain health through the Atlantic Fellows for Equity in Brain Health program, by collaborating and expanding preventions and interventions, and by sharing knowledge and engaging in advocacy. The Atlantic Fellows for Equity in Brain Health program at GBHI provides innovative training, networking, and support to emerging leaders who are focused on bringing about transformative change to improve brain health and reduce the impact of dementia worldwide. And now you're going to hear from some of these fellows and their friends today. So I just want to remind the speakers that they each have 10 minutes only. I have to be very strict about that as the Deputy Executive Director. And then we will have question and answers at the end through the chat function. Now, if I can just introduce our first speaker. Our first speaker is Stefania Ilinca. She's a health economist and researcher based at the European Centre for Social Welfare and Research in Vienna. And she's going to speak to us about gender and economic differences in modifiable risk factors for Alzheimer's disease and other types of dementia throughout the life course. Stefania is originally from Romania. Over to you, Stefania.
Thank you very much, Brian. I'm hoping you can see my screen. Could you please confirm if you can see my screen?
Yes, we can. Okay.
And hopefully you see it in a better format than mine.
You can click.
Okay, there you go. Yes. Okay. So there you go. I lost 1 minute. So yeah, today I'd like to talk to you about gender and socioeconomic differences in modifiable risk factors for dementia, looking throughout the life course. And I'd like to start with this ADI infographic, which will likely be familiar to many of the participants today, that tries to depict the global impact of dementia around the world. And the numbers you would see, I have no qualm with. I think they're probably correct, if maybe somewhat optimistic. I do think that it's important to point out that the picture, the description is a tiny bit misleading, because the little figures here on the slide are all the icon we use for men. But the reality of the dementia impact around the world is that 2 out of every 3 people who live with dementia are women. The risk of developing dementia is almost twice as high for women as for men at age 65. And approximately 70% of carers around the world, this is of course an approximation, are thought to be women. So the burden of dementia is disproportionately borne by women around the world, and particularly older women or middle-aged women at that. And why would that be the case? Well, I chose a quote at random out of an article that was otherwise excellent. And they said, much of the gender gap comes down to one of dementia's biggest risk factors, age. I don't know, I'm not familiar with the research that has actually established how much of the gender gap comes down to age exactly. But what I do know is that there is really very little research that looks at alternative explanations. There's a little bit of information about the role biological differences might play in creating this gender gap. There are differences in diagnosis and in testing performance between women and men that might contribute to it. But there are also gender differences in risk factors throughout the life course. And this is what I'd like to talk a little bit more about today. The new Lancet report came out, of the Lancet Commission report came out on dementia prevention, intervention, and care. Just this year, they have added a few risk factors to the ones you already know. There are now 12 recognized modifiable risk factors for dementia. Most of them are known to be associated with low socioeconomic status and poverty, and most are more prevalent among women. None of these issues, the aspects related to gender equity and to socioeconomic equity, were addressed explicitly in the report. And I won't be able to address all of them here today, although I encourage you to follow our upcoming publications for that. But I want to give you just a few examples in the few minutes that I have. So one important modifiable risk factor that has a large gender dimension is depression. And you would have probably seen graphs like this one, plotting the prevalence of dementia by age group and by gender. So the yellow bubbles, the orange bubbles represent women and the blue ones represent men. And what should be very quickly apparent from this graph is that in each age category, the prevalence of dementia is considerably higher among women than among men. And importantly, we see the highest prevalence rates among older women. So they are a group most at risk. And this risk, of course, affects their dementia, the risk of developing dementia later in life. What is the less common, or at least I have seen less depictions that built into the same picture the aspect of gender and income jointly. This graph uses exactly the same data, but breaks down the information not only by gender, but also by income quintile. So we have plotted here prevalence rates for depression, excuse me, by gender and by income, the lighter colored bubbles representing the poorest individuals. And here I'd like to pause to really make two important points. First, should be fairly obvious, and that is women generally, as in the graph before, have higher prevalence rates than men for depression in all the countries that were surveyed and in the EU28 as a whole. There are, of course, differences between countries that can be explained by idiosyncrasies that are cultural, social, related to general public health status, and aspects like this, but by and large, this association holds. What I would also like to point out is that the gap between the poorest and the richest actually is larger than the gap between women and men. So generally, we see that inequality in certain risk factors, probably the majority, is actually larger when we look at poverty and at income and at living conditions than it is between genders. I can make the same point with another indicator, another of the risk factors recognized by the Lancet Commission, and that is social isolation, an aspect that's become much more relevant in light of the pandemic. And again, the same is obvious as before. The gap between genders is evident, but even larger and more evident is the gap between lower and higher income individuals. And the most disadvantaged group in all these situations are women who live in poverty. So women who live below the poverty line, these would be all counted under the poorest group here, so the lowest income quintile. So hoping that this has been fairly clear. Again, I can't show more graphs here for the sake of time, but this is true for most risk factors. It's true that there are risk factors that favor men with respect to women. Smoking is one of them. Physical activity is one that, again, is in the favor of men with respect to women. Low education is an interesting example because there is still a very large gender gap in education between women and men in older cohorts, but that gap is narrowing, if not reversing. So as newer cohorts progress to old age, we will see a reduction in the cases of dementia. Sorry, Brian, you wanted to say something?
No.
Oh, sorry. Okay, your picture just popped on my screen. Okay, so why is this important? Well, it's very important to think of gender and socioeconomic status jointly because women are, by and large, the group most affected by poverty, and older women at that are extremely vulnerable to poverty throughout Europe, but really in most OECD countries and throughout the world. I have added here a really small graph to make this point, but I think you can still get the message. And it's important because at the intersection of gender inequality and socioeconomic inequality, older women are particularly vulnerable to the detrimental impact of low socioeconomic status. So not only do we see that women have a higher prevalence of poverty, but we see that the impact of poverty on health is larger for women than for men. There are many explanations that can contribute to that, but the association holds. And while these differences, there might be differences in the causality mechanisms between world regions and countries, the general pattern of association is always there. So what is my message today? It's really simple. To me, gender equity is a direct pathway to the prevention of millions of dementia cases. It's essential that we build a population health approach and the focus on promoting equity in health and access to care for dementia prevention. So if you're seriously an advocate for dementia prevention, then you're also a feminist and you're also an advocate for ending poverty around the world. And it's important to understand that the interventions that are necessary go way beyond the limits of health systems. We're talking here about equity at a societal level that needs to be addressed at its root causes. It's well known that despite large gains in medical advances and medicines and pharmacology, to this day, the largest gains in life expectancy and in the reduction of morbidity around the world can be put down to public health interventions and to improving standards of living around the world. And we like to believe that that era is gone and technology is going to be the next big savior of lives and reduction of disease. But there's still so much more that we can do, and dementia is a great case in point, simply by improving standards of living and by increasing equity and focusing on equity on everything we do. That's it for me. Thank you very much. I think I've managed to stay within the 10 minutes to a T, and I look forward to your questions and to discussing this forward. Thank you.
Stefania, thanks so much for a wonderful presentation and for sticking to time. So we'll have questions for Stefania in the general chat. Maybe people can put questions in now if they wish, but we'll answer the questions at the end of the when all the speakers have finished. So thanks again. Now, our second speaker is Ieva Petkute. She's an art researcher, facilitator, and manager from Lithuania. And Ieva is going to tell us about empowerment through creative engagement, arts for health practice in Lithuania. So over to you, Ieva.
Hello, everyone. Thank you so much, Brian, for introduction. I'm so honored to be part of this event and to share my work with you. So, just a second. Yeah. So today I would like to speak to you about some initiatives we've been delivering in Lithuania and through the lens of empowerment through creative engagement and arts for health practice in Lithuania. I come from an NGO where we lead diverse range of practice, and as well I'm a senior fellow in the Global Brain Health Institute. I would like to start my presentation sharing 3 stories with you. And these 3 stories come from the people I met during the work I've delivered. And they give me permission to share these stories in this event. So the first story is by Patras. Patras is the person that I met was a very shy, worried man carrying a huge bag with him, and that huge bag was contained all of his life. So he was a person that I met in a canteen that provided food and shelter for people that experience poverty or homelessness. So he was as shy and fragile as this leaf that he drew in the activity that I met him for the first time. We invited him to join an arts project that had eventually resulted with a huge exhibition in art gallery. He was very, very shy to do so, and he was very worried and very mistrustful towards the people. So we started by inviting him just to sit nearby and observe and maybe start doing something together. Afterwards, we invited him to join our tour in a gallery. Since the project had to result with exhibition, we found out that most of the people that experience homelessness and poverty, they've never been in a gallery that they want that the exhibition will take place. So this is Patras in the gallery, and that was the usual outlook he would be looking like in the activities that we met. And the tour that we offered him included the discussions near the artworks and discussions in the group. So the artwork was something that we reflect on, and we actually share things that we experience in a life. So he really enjoyed that activity, and as he said by his own words, I've never imagined that I could join an activity with people that I don't really know well. So as he really had positive experiences, you could see on his face and in his outlook how he really put an effort to come to in the exhibition place next time. As we gave him a positive feedback, "Oh, Patra, you look so nice today," he said, "You know, I really appreciate. I will try to keep that outlook later on." And he actually kept on like this. I had a chance to visit where Patras lived, and that's a homeless shelter, which is absolutely not a place that I would like to spend even one night. And I was really impressed to think that our gallery visits that took place once in a month kept him in a positive mood to come and join in a really positive, maintain the positive energy that he received during the one visit a month ago. So Patras, he kept on going with us until the project ended. And actually this is the fragile leaf that at the end was exhibited in the National Gallery of Art at the end of the project. That was the reason for him to join our activity. Another story I want to share is by Patras, another Patras, and Odrona. So they are a couple, and Patras is a person that lives with Alzheimer's disease. They joined activity in another city. There was a Kaunas Biennial contemporary art exhibition program, and that's how they started going to these visits. And the activities, again, they were about discussions near the artworks. And I really want to share what Odrona reflected after the activities. She said that the experience that we received was something that was restorative towards our connection with each other. So in that space, we know more a patient and a carer, but we again are a wife and a husband. And that is something that fills us with a positive energy that we keep not only during the activity, but also at home as we come back, and it really reflects on our daily life for quite some time later on. Another story I want to share is by Sandra. Sandra works in a day center that provides specialized services for people with Alzheimer's disease in the capital of Vilnius. And she is one of very, very dedicated persons that absolutely invests everything she has and knows in the work. But at the same time, she's very sensitive towards what's happening in the environment. And that burns out her as a carer enormously. After she comes back from the holidays, she says, like, after a week, I don't feel that I had holidays anymore. So the activities that we invite her to join, which means that you have to go from day center outside to the gallery space, and you can imagine how many organizing elements that might include. In the beginning, she was said, like, every time we left the day center, it was something enormously hard for me to experience, both as a person and as a professional. So she was very worried to start doing these activities. But at the end, it went all very, very well. And she reflected through her experience that it was not only a positive experience for herself and observing what it meant for the clients that she worked with, but it was a transformative for her as an art, let's say, as a service user of an arts gallery. And I want to quote her saying that, I was absolutely surprised to see that I saw things and I heard them seeing the same things. And it was just so incredible to understand that we really see the same things and we discuss on the same elements, and that absolutely removes the barriers that normally we have in a client and service and a service provider relationship. That was the story of Sandra. As I met her. And these three stories, they come from activity that we lead in Lithuania, which is a susitikime muziejuje, and initially it was based on the Meet Me and Moment model, which is about visual thinking strategies, employing the conversation about artwork in a gallery and reflecting on your life. So it includes a very clear structure, speaking about the descriptive elements, then connecting with the artwork and interpreting it using your experience in life. So, but we just started that as this model for Lithuanian context, but we employed numerous other approaches that helped explore artwork as movement, tactile experience, and conversations through poetry or song. So, as for introduction, Socialnie Meno Projekty, the organization, I believe, they implemented numerous programs, and it includes training, workshops, events, and artwork production, and research and publishing. And this all is about access to arts and health and well-being. And the principles that apply is advocating for arts as a human right and doing the things that we do with the respect, with the aim of empowerment, person-centeredness, ensuring quality, equity, and access. And I put these things not accidentally together because I do believe that if the activity is accessible, that's equality. And it also promotes a holistic approach towards health and well-being and cross-disciplinarity and the enriching process for everyone involved. And in here, I really want to stress one aspect of that work is as a transformative change for everyone involved, which is through the empowerment. And empowerment, it not only acts, it acts in a different levels, but it's very important to stress as the work that we do is arts for health. And in a health environment, we can notice that empowerment as a strategy becomes even more important. And WHO stresses that empowerment is authority, permission, or power given to someone to do something, or the enabling process of becoming stronger and more confident, especially in controlling one's life, health, and claiming one's rights. So that absolutely connects arts and health, not only as a process, but also as a in an aiming, as an aim and as a result that can achieve applying these strategies. So again, it acts in different levels in individual, organizational, community, and societal. And we apply the 5 ways of well-being model developed by the New Economics Foundation. And it is really a lot about doing things differently and not being afraid to do so. And in here, I want to share, like when I say doing things differently, it really leads into more like societal changes that activities like that and the stories that, of Patras, Ojone, and can result in a longer term is this is a research which results by a toolkit which enables arts organization across Lithuania to become more accessible. So it's evaluation that was done based on the barriers that people living with dementia experience while participating in arts activities in the museum. And another transformative in a larger scale initiative is very much positively, absolutely influenced by my fellowship in the Global Brain Health Institute. So we just received funding for the 3-year project, which is about towards a dementia strategy development, about situation analysis and public awareness, which would be funded by Active Citizens Fund. And as an incredible element of that is that arts organization is leading an initiative which includes organizations that work across the spectrum of the services of that people living with dementia need. These are the partners that are involved in the project. As Lithuanian Health Sciences University, Sports University, Alzheimer clubs, and national broadcaster, as well as the Ministry of Health. And I really want to conclude this presentation with enormous gratitude to the community that I joined during my fellowship, and for you as an audience listening to my presentation, and with the wish that it is really not forbidden to walk on the grass. It is not forbidden to fly over the grass. So it's a quote by a theater artist from Brazil, and I assume all Brazilians do know him as a somewhat absolutely transformed artistic experience in the theater field. So we can be inspired by him and to do things across our work field. Thank you very much, and I do expect for 1 or 2 questions if there are.
Ieva, thanks so much. We're going to save the questions to the end. I think people are putting them in the chat function, so we'll ask those questions at the end. But thanks so much again. A very different type presentation, but still the theme. There's common themes in terms of equity, inclusion, and access for people with dementia. So now we'll move on to our next speaker, Chen, who is a neurogeriatrician from Lille in France. And Yao is going to tell us about models of memory clinics in the north of France.
Hi, everyone. I'm Yao. Indeed, a different presentation also from Ieva and Stefania. I will try to share my screen here. Oh. Yes. So I would like to present the model of our network of memory clinics in the north of France. Memory clinics, they are specialized healthcare facilities in which multidisciplinary teams, including physicians, usually nurses, social workers, neuropsychologists, and speech therapists. They provide diagnostic workup of neurocognitive disorders and appropriate management. The first memory clinics were set up in North America during the mid-1970s and shortly after in the UK. And since now, memory clinics were established themselves in developed countries as the main model for dementia diagnosis and care, and also as a secondary referral care for people with mild cognitive impairment and subjective complaints. But the organization and the working methods and the services of memory clinics remain highly heterogeneous from one country to another. So the first memory clinic started in France, in Paris and in Lille in 1991. And shortly after, 20 memory clinics were established over the country. There have been successive national plans for Alzheimer's disease and related diseases. The first one in 2001 will contribute to stratify different levels in resources with the creation of a memory and resource and research center, which we will call MRRC. And in 2008, memory clinics received a strong boost from the presidential national plan, le plan Alzheimer. And at the end of this plan, we counted 469 memory clinics nationwide with 28 MRRC. And the very last plan was designed for all neurodegenerative diseases, including Parkinson or Huntington's disease. So it certainly diluted the funding for each pathology. And this is the usual pathway in France when someone have a cognitive complaint. So they were asked to consult their GP, and who will decide to refer the patient to a local memory clinic represented here by a hospital. And sometimes the GP can decide to refer the patient directly to a MRRC, represented here by a superhouse. In the case of, if the case of this patient is complicated or hard, the memory clinic can decide to refer to MRRC of their region. And sometimes, so in the memory clinic or in the MRRC, they will be offered a management plan in collaboration with their GP. And sometimes they can also be referred by other specialists than GP. It could be a surgeon, for example, or yeah, just any kind of specialist can also refer to a memory clinic. So I talk about the MRRC, the Memory Research and Resource Center. Usually there is one MRRC per region, and it includes a multidisciplinary team as other kind of memory clinic. It is supposed to work with from 6 to 44 memory clinics, depends on your region. It is also a referral center for GP. But it is especially a tertiary center for atypical clinical presentation or people with young onset dementia. Besides the action in clinical care, MRRC will also be asked to provide professional training, and they are often the PI for different research protocols, and they are involved in ethical considerations. And of course, they are responsible for the regional coordination in dementia care. So now in the north of France, here in the blue star, the first memory clinic started in 1991. And 2 years later, we opened another memory clinic in a rural area with a successive, with a very good experience. So after that, we developed different memory clinics in this region, with also a creation of the National Referral Center for people with young onset dementia in MRRC of Lille. And this memory clinic can be managed by neurologists or geriatricians. These different memory clinics are soon organized as a healthcare network with a harmonization of diagnostic workup and data on patient characteristics and healthcare resources are systematically collected in all memory clinics since 1997. And all data are monitored and computerized by a data manager in the memory clinic of Lille. Over 20 years, the number of memory clinics increased from 12 to 29 in 2016. And we looked also the change of characteristics of people when they first attended into any of these memory clinics to see if there is an impact of this network. These are the results that I want to share with you. So from 1997 to 2016, 93,617 new patients were referred to the memory clinics of our regional network. New consultants raised from 774 in 1997 to 26,258 in 2016. And to be sure that this increase is not due to the geographical modification, to the demographic modification in our general population in the region, we adjusted the number here by age and sex, and we confirmed the increase of new consultants. So we defined 5 equal time period during these 20 years. I choose to name them as P1, P2, P3, P4, P5. And in the whole network, as you can see here, the number of patients increased in all age categories. The highest increase from P1 to P5 was observed for the oldest patients. So when they are aged above 85 years old. And in the MRRC, the increase was the highest for younger patients, so patients below 55 years and patients aged from 55 to 64. In all centers, the proportion of less educated patients increased with time, especially for people here in blue with any education. And thanks to the creation of new memory clinics, which cover largely our region, the majority of patients lived within less than 50 kilometers from the memory clinic. And this proportion gradually increased over time. More than half of the patients were referred here in green by their general practitioner, and this proportion remained overall stable over time. At the same time, the proportion of patients referred by specialists increased here in purple, reaching almost 40% in the last period. And very few patients here in red came by themselves. We also observed a shortening of the delay of consultation, so which means the time from the first symptoms to the first consultation. The delay, the referral delay was shorter in all memory clinics, about 6 months shorter in the last period compared to the first one. But we can notice that in the last period, there is a slight rebound in the delay. The same shortening was also observed in the MRRC over time, but overall, the delay was longer in MRRC compared to all the memory clinics. This is probably because we also saw patients with atypical presentation and a young onset dementia. So when we are talking about the clinical presentation, when we look at the distribution of the first clinical diagnosis, there was a decrease in the proportion of AD in all centers, and particularly in MRRC, here in gray. And the diagnostic distribution was significantly different in the MRRC compared to the remaining memory clinics. And there was a higher proportion of frontotemporal lobar degeneration in the MRRC compared to other memory clinics, which represents the third cause of dementia in MRRC. So overall, the development of a network of memory clinics in the north of France was effective and because we saw the change in patients' characteristics over time, with an increase of more vulnerable people who were older and with lower level of education. We saw a shortening of the referral delay, and patients were also more often referred by other specialists. And we observed a better use of resources because in our tertiary center, we observed more and more younger patients demonstrating a better use of the resources. And also it is important to see the collaboration between different disciplines. We still have a lot of challenges because we are facing the problem of sustainability of resources and funding. As I show you, the last period, we saw a slight rebound in the delay of consultation. We observed a lack of trust from some of the GPs and also a disinterest from some young physicians. We will need more professional training. During my fellowship in Dublin, I saw some advanced skilled nurses. We did not have them here in France, so we just started the training this year. And of course, there is also opportunities and challenges with the COVID about the telemedicine. So thank you very much for your attention. I want to thank all the professionals involved in our network of memory clinics. I want to thank you for listening to me. And yes, see you later for the questions.
Yeah, thanks very much. So a lot of shared learnings, and I see bi-directional learning. We're learning from France, and France is learning from Ireland, and that's the way it should be. So well done. So our next speaker is another neurologist from a different country, Clara Dominguez-Vivero. Clara is from Galicia in Spain, and she's going to talk to us about building an online support service for people living with dementia and their caregivers in her home province of Galicia.
Yes, thank you. And yes, I'm presenting this project that we have to develop here in Galicia. It's a web-based tool to improve social prescription in this area of Spain. So for those of you who don't know, social prescription basically consists on referring people to a range of local non-clinical services. So it's not so focused on the medical aspect of disease, more on the social needs of patients and their caregivers. And it's trying to address these needs in a holistic way. It's normally addressed to people that has mild or long-term mental health problems, also other vulnerable groups and people who are socially isolated. So in the particular case of dementia, that is what we are working with, it has demonstrated to have the level of evidence regarding its benefit is very high. Actually, it's the same level that we have for pharmacological treatment, as you can see here. So for example, a structured physical exercise program has the same level of evidence as cholinesterase inhibitors, or cognitive stimulation, the same level of evidence as adding memantine to the baseline treatment. And these are some of the activities that we can prescribe our patients and that can really help them. So leisure activities, mental stimulation programs, occupational therapy, or exercise. They normally help a lot with neuropsychiatric symptoms, but also help to improve cognition and overall quality of life. And not only for patients, also, or for people living with dementia, also for their caregivers. So basically non-pharmacological approaches have shown evidence in many, many studies of improving quality of life in caregivers, particularly psychotherapy, education, support groups, and multidisciplinary interventions. So we are trying to improve these services in Galicia. And Galicia, as you can see, is here in this tippy top of Spain. It's actually an area that is a lot like Ireland, so rains a lot, we have bagpipers, but it's very different looking at this map, as you can see. And I'm interested in developing this here, of course, because I'm from here, but I think it's also very interesting because we are one of the fastest aging areas in Europe, as you can see here. The fact that we are yellow in this map means that we have almost 30% of our population are considered already elderly. And here you can see our population pyramids. You can see it now, but like just in 10 years, it will look this way. And not only that, but this map here below shows that we are in an area of Spain that has the highest rates of working people living abroad. This means that our elderly population is not only very numerous, but they are very alone because their kids, most of them are away. So now we're going to go to a practical imaginary case. Okay, so let's imagine this woman. Her name is Dolores, and she is starting to present symptoms of mild cognitive impairment. She lives alone with her daughter's help that lives nearby and lives in a small village in the coast. And she has no idea about the kind of services that she can get to have a better quality of life. So they travel to the nearest town and they visit the neurologist that could, let's name her Maria. And unfortunately, Maria has only 30 minutes to explain the diagnosis, the prognosis, and the treatment to Dolores and to her daughter. She has no social worker. She has no specialized nurse or psychologist to help with information. So she tries during these 30 minutes to recommend cognitive stimulation and exercise, and also tries to talk with Dolores' daughter about you should take care of yourself, you should look for social support. But as you can imagine, this is not easy to do in 30 minutes. And I know because I've been there. So if you have to explain the diagnosis and the treatment, in the end, you end up not explaining all the other things that are maybe even more important, right? So the best scenario after this clinic consultation is that Dolores' daughter has the skills and also the will to look for resources at home. And she finds family associations in the nearest towns, and also a lot of websites with information, but she really doesn't know if she can trust them. And this is what they don't know. They don't know that there are some feasible options that are really nearby their home, like, for example, an age-friendly gym or walking groups or a choir that Dolores could join to improve her quality of life. So the aim of our project is to increase social prescription in Galicia, in our area, and make it easier for clinicians, easier for patients and caregivers. And we know we have to do this at a low cost, because we know we are not going to get a lot of money from the government initially to develop this. And as a secondary objective, we would like to improve also the availability of non-pharmacological treatments. So this will allow us to reduce the cultural and geographical inequalities in access. It's not as easy if you are in a city, or if you have a high educational level, you have access to more resources. And also we want to promote the creation of new services. And so we are lacking a lot of services, but fortunately we have something good here, and is that we have a good website from the health system. It works very well. It has access for clinicians and access for people living with dementia and their caregivers, and their data are completely protected. So how will this project work? The clinician, when they give the diagnosis of mild cognitive impairment or dementia, will register the patient in the consultation. And they will even give a printable version of a personalized pathway to follow to the patient and their caregivers. And it will include lay information about the disease, about the treatment. It will include a list of online trustworthy information resources if they want to dig a little bit deeper on everything. It will have like a next step guide with financial advice, legal advice, long-term care planning advice, and also a lot of information about non-pharmacological treatments. But the most important part is what the patients or their caregivers can access from home. They will be able to navigate a website completely designed for them, including basic information, educational videos, which I think are very important, that will be culturally adapted, trusted online resources, and most importantly, a provider's map where they can find all the services that they can have nearby. So these are the outcomes that we are expecting to reach with this project. Regarding non-pharmacological prescription from the prescriber point of view, from the clinician, we would like to make it one more thing of the dementia clinic, like and embedded in a clinician's daily tools. So we think it has to be easier for them to become common practice, and it has to be something that doesn't get more time or increase the cost of the clinic. Regarding the community resources in Galicia, we think it will help to increase the number of them, will help to make them more accessible to everyone. And then we will also have the scarce services like social workers that there are, but we can save them for those cases that don't have, for example, any support, so they can focus on them. And then we will also have the first inventory of resources for non-pharmacological treatment in this area. And for people living with dementia and their caregivers, they will have a personalized pathway, they will receive quality information and have access to culturally adjusted educational resources. The potentialities of the project is also that it may allow us to demand more public services to authorities, because we will do an inventory and we will see where we are lacking services or what areas are underserved. We also think that private providers will be included and will be more public to the patients. And we hope to improve the coordination between family associations and health services. If we get more funding in the future, that I hope we will, we aim to include navigators or a helpline that will help people navigate this new resource. And we also think that it's a good project to export to other environments where budget is limited and there's a lot of elderly people facing this situation. And this is our project. Thank you very much for listening. I hope this is useful for someone else.
Clara, thanks so much. I mean, I think everything that you've described there it's not just useful in Galicia, but useful the world over. I mean, it's a wonderful tool, I think, and I wish you every success. And you have to report back to us, because I think we'd love to try and use that here in Ireland for sure. So thanks so much. So, and I'm sure there'll be lots of questions. So we're talking about global aspects of dementia care. So we've been focusing Europe, Eastern Europe. Now we're moving to South America. So our next speaker is Fernando Perez. Fernando is a journalist from Brazil, from the south part of Brazil, around Porto Alegre. And he's going to tell us about his personal experience of caring for his grandmother with Alzheimer's disease and the use of storytelling to change the way a stigmatized country perceives dementia. So over to you, Fernando.
So first of all, I want to thank Brian, Wambui, and all the team for the hard work and for inviting me to participate. And yes, I have been asked to tell a little bit about my own experience in the context of Alzheimer's, and to honor this 10 minutes that I have to summarize more than a decade of journey, I would like to begin by introducing someone really, really special, the protagonist of this story. As you can see the picture, this is my grandma, Ieva Aguzzoli. She was always so passionate and so devoted as a grandma. She was my hero since always, but she lived a really, really, really painful story. The poverty in her early years led her to drop her studies at 13 to work in a factory in order to help sustain her home. And she used to enter before sunrise and leave the factory after sunset. and life played a lot of tricks. Her father's murder, 10 years of domestic violence, but everything changed when she became a grandma. She had a wonderful, wonderful knowledge, and she could talk about literally everything about the world, mathematics, philosophy. She could quote poets and great names in history, writers, everything, because she was afraid I could need help for a school homework or something, and she wouldn't be able to help me. So she studied 3 times more than I did. And she could have been just a grandma, one of those where the bond between you both hunty, and she could have chosen to be a selfless or a missing grandma, but still the bond is there, wanting or not. However, my grandma taught me something that today is quite important to me, and I try to tell all the caregivers by using storytelling to shift the mindset of these families. The value of a reserve of affection as much as a cognitive reserve that is widely known today in dementia field. So we became friends, and at some point, my grandma was my very best friend. I don't know exactly when that happened, but she was my best friend until the end. And if I was interested, for example, in anything that could spark a nice dialogue or something, she would read Harry Potter, Lords of the Rings, while I watched her black and white movies and learn how to knit, although I was really, really bad. So my audio is good, right? Yes, okay.
Audio is fine.
Okay, thank you, Brian. However, things were a little bit different. And after a year trying to find out what was happening to her, the doctor said that most probably she was experiencing Alzheimer's. That was the first time I heard about the disease 15 years ago. And I thought, well, it must be okay. And when I got home, I made the biggest mistake someone could do after talking to a doctor. I went to Google and I discovered a really hard disease, much more severe than I actually pictured. And Clara is right. When you go to the internet just to discover what is happening to you, it's kind of funny because Google is almost always trying to kill you, even if the diagnosis is not yours. And they will try to kill you anyway. I remember, I will never forget the first article I read in our main newspaper at the time. And it was saying, caregivers often die before the person with dementia as a result of the burden. So my grandma was diagnosed with Alzheimer's, but Google was still trying to kill me in somehow. And I went to a really, really, really bad place reading everything that I discovered about Alzheimer's at the time. And discovering an incurable disease in someone we love seems to be a tremendous failure for us. If not the person who will provide the cure, who am I in this journey? That was my main question at the time. It seemed to me that everything and everyone expected me to sit down in a table and accept the decline of my grandma, knowing that I would be not responsible for any victory in our days. So the fear, anger, and the lack of a positive or compassionate content led me to the first stage, what I consider to be the first stage of the acceptance of her diagnosis, the systematic denial of everything happening there. I decided to buy the idea of my grandma just getting older. And in Brazil, we have a word for that, it's caduco, or actually someone expiring and suffering the consequences of it. Everyone knows we shouldn't cure aging, but when there is a diagnosis there, for us as a family caregiver, it's a huge failure, not being able to heal. So very briefly, one day in the room with her, she was looking to me weirdly sometimes, and she finally asked me if she had grandchildren. And I literally fell. I just remember falling into myself, and I yelled, I cried, I argued with her. And when I told the doctors or my friends at the time how it was, they all told me the same. You can't react like this. And today I try to do the opposite in my lectures, making caregivers feel comfortable wearing their emotions, helping them to understand and to improve their reaction. Sorry, someone is saying something?
Don't think so, Fernando.
Oh, okay. So Alzheimer's is maybe one of the only diseases that is faced by the other that allow us to make a mistake. In 5 minutes, we will have the chance to correct without any resentment and rage, but fully aware of our own mistakes. As a caregiver, we will be better in tomorrow than we were today. And this will be a constant process. I accepted my failure every day, knowing that in the next day I would be better. And at that day, she responded, Granny forgot she had grandchildren, but not that she loved you. And from that moment, she forgot me every single day until the last, but never forever, many times a day. And she was right. She used to look laughing and say, I know I love you very much. I know that, I swear, but I can't remember why. And each of those thousands of times, I was better than the last one. And today I understand my explosion that day, because it was at that very moment I understood that nothing in the world would make my grandma forget about myself if it wasn't a disease like Alzheimer's. So I came out of denial and I began to unveil the disease that would follow us until the end, making peace with that. And well, I promise this is the last slide. From that moment, I started to learn a lot and to discover my victories, even smaller than I wanted. And that's why I decided to share these lessons, first in social media with hilarious dialogues, then in books telling our great adventure. One of these wonderful lessons was to understand that Alzheimer's is in somehow distance yourself from reality in order to get closer to imagination. And I will explain that in just one phrase that all of you heard in this context. Where is my mother? She would ask me many times a day. And whenever this happened, I decided to tell the truth. My grandma taught me that tell the truth regardless of the consequences. And in this case, the consequences will be seeing her crying for hours. Many times I cried together. And the truth brought sadness and frustration sometimes. First, for understanding that her mother, someone so special, had died, reliving the grief with the same intensity, and the frustration when she realized having forgotten something so important. So the curious thing is that she was still sad even after hours. But if I asked, why are you sad? Why are you crying? She would invent any reason to justify her feelings. And she didn't know the reason anymore, but she knew she should feel it. Happiness worked the same way for her. Once she asked me about her parents, grandparents, people I'd never heard of. I used to say, when she asked me, so what about that person? I never heard about this person. I used to ask her, so it was older than you? She said, yes, much older. So it's dad, probably. I didn't know who these people were from the past. And this time she asked me about a long list of people, and all of them were dead. At the end, she looked at me deep in my eyes and she said something that I will never forget. It's so hard to forget this horrible moment, but you insist in reminding me. So every next time she wondered about her parents, I will tell her that they were traveling around the world on a trip, and I would make sure to mention that she had given it to them as a present. So the humble lady who had been poor all her life, who had seen her father murdered at the age of 15, and who had never been able to take her mother to the beach, now was sleeping with a smile never justified in words. So this was all possible because at the very beginning, we built together our reserve of affection. When she needed it most, there was someone willing to quit college and company to make sure that she could die being the person she had been during her entire life. And well, I know we are finishing here, but I have just one more quote. I used to say in my lectures that the cognitive reserve is like the walls that surround a sand castle in the beach, so the waves don't crumble our work, our hard work. And it is as if the castle were our brain surrounded by strongholds, and however, when your reserves dry up, your cognitive reserves dry up, when the walls are broken down and when the waves move in to take your castle back to the sea, who will be at your side to rebuild it and help restore your identity? So that's the message that I try to bring to people, and with my work and advocacy, bringing my own storytelling to shift the mindset of them. And I guess the main message is, it seems a huge failure, but there is a lot of victories to win every day, every single day. Each day is a victory. And well, that's it, guys. Thank you. That's a little bit of my journey with my grandma.
Fernando, thanks so much. And emphasizing the importance of, of telling stories, but also the importance of inclusion and connection. And I think, again, this is a common theme through many of the talks this afternoon. So thanks again for sharing that and all that you've done for your grandmother. So we're now moving to East Africa, and we're going to have two brief presentations. The first one is from Wambui Karanja, who is very much leading on the symposium and pulling all the speakers together. So thank you so much for that, Wambui. So Wambui is a senior Atlantic fellow, but now she was here in Dublin last year, back in Kenya. She's a background in psychology and dementia advocacy, and she's going to tell us about building an online course for family caregivers, the Dementia Education Exchange project between Ireland and Kenya. So Wambui.
Thank you so much, Brian, and I'm really glad to be. I hope you can hear me. First of all, I'd just like to state that this session makes me really proud in what it means to be an Atlantic Fellow for Equity in Brain Health, that over time we have come to break barriers of language and disciplines and culture and geographical locations, and we learn from each other and we listen to each other, and I think there's a lot of value in that. And as I bring my presentation, it's about listening and the learning process that I came across in GBHI. First of all, I'm going to give a brief background of Kenya and aging in Kenya. So majority of the population in Kenya is young and have a youth bulge. So we are experiencing population aging. So there's not much research done on aging, and there's a low awareness of geriatric diseases, including sort of like dementia and other neurological diseases. There's low awareness. And with low awareness, there's low support systems for people with dementia. And in a population of almost 40 million, you only have 15 to 20 neurologists in the whole country. So I'm going to talk about Alzheimer's and Dementia Organization Kenya, which is an organization I've volunteered for a few years. And this is an organization founded by Elizabeth Mutunga, and its aim is to create awareness on dementia and support caregivers of people with dementia and people with dementia. So today I'm going to talk about dementia exchange program between Alzheimer's Society Ireland and Alzheimer's and Dementia Organization Kenya. And I'll start with the beginning of COVID in March, and when people could no longer meet and when there was lockdown in Kenya, we started an online support group meeting on Zoom. And this was very popular with caregivers in Kenya, and I think this gave a potential for the project that we are currently doing, that caregivers need learning. And partnering with Alzheimer's and Society Ireland, we are developing an online caregiving platform, an online caregiving training, a training for family caregivers. Sorry, English is my third language. A training program for caregivers in Kenya, and we are learning from Alzheimer's and Society Island, and this is one of the greatest lessons I've gained from being a fellow. So, so we have in the last 1 week we have done a survey that shows that the needs of caregivers in Kenya are similar to those of needs of caregivers in Ireland, and this just encourages us to develop a course that sort of like, as we learned from Alzheimer's Society Island, we also get to we also get to understand the needs of caregivers here in Kenya as we learn from them and as we develop the course. And one of the courses that one of the things you're going to do is, the first thing is a module that's a 4-week course, and we'll be inviting caregivers to form peer support networks in up to 15, and they're creating a WhatsApp group. And I just want to go back to the stereotypes of what Africa is and how people interact and all that. There's good internet access across the country, but then also mostly in urban and peri-urban areas. So because the caregivers can access the internet, it's possible to create an online learning platform. So it's creating peer support system and also sharing information on and resources on where to find support systems for dementia. And the next step of the project will be trying to translate that course into Swahili, so that we have a bigger access to caregivers who don't speak English and who are also not in the peri-urban areas and also have lower levels of education. I'm now going to invite Purity, who is a fellow Kenyan and a researcher who self-funded to do research on dementia and the caregivers in Kenya. And Purity, take it away.
Well, I just introduced just the same word just about Purity, just while she's getting ready. Purity is a postdoctoral fellow in the School of Nursing and Health Systems in University College Dublin here in Ireland, with a focus on global health and social determinants of health. And she's got, she's pivoted now and got a very special interest in the whole area of dementia and brain health, and has been working closely with Wambui. So welcome, Purity.
Thank you very much. Sorry, my voice is not very clear, so just bear with me. So thank you so much for inviting me. I'm really delighted to be part of this this forum. I had some slides prepared, but I'll just quickly really talk because I see time has gone.
Would you like me to share those slides?
Yeah, you could. Yeah, you could.
Let me try if I can do that. Can you see that?
Yes, exactly. Yeah, thank you very much. So today I'm just going to talk about some of the work that I did last year in Kenya, but I'm not going to talk about the project itself. I'm just going to talk about my experiences doing that piece of work, because I think this is important for people who would like to do such work in that context. It's probably something that they can learn from that. And thank you, Wambui, for giving us that that background to the Kenyan context. So I think what we know is that family members in Kenya are most of the time, if not all the time, the only support available to older members in the family or those with chronic conditions. And this is mostly a result of the culture, but also the limited government support we have in the country. There's also limited consideration of dementia and no national dementia policies, so which make caring for people living with dementia very, very challenging. There's also very little understanding and knowledge of dementia. I know that is changing now among caregivers, among families, healthcare professionals, and the public. I mean, often dementia is viewed as a normal part of aging and at times associated with witchcraft. And based on a recent scoping review that my colleagues and I did, we found very little evidence in Kenya about how caregivers manage their role and their caregiving experience. So in line with that, I thought of doing a project to really understand the experiences of providing care. But one of my greatest motivations of doing this study was really my personal experiences of having a parent who is living with dementia. but also having being a caregiver for people who live with dementia in Ireland. So because I had limited knowledge of dementia, I decided to take to self-directed learning. I enrolled in the Understanding Dementia and Preventing Dementia courses offered by the University of Tasmania in Australia. But then, of course, came the question of funding the study. So I needed, money to travel to Kenya to do this work. So after several attempts to get funding, I couldn't secure the funding, and I just decided to self-fund the study because this is something that is very important to me. So I did. So I'll talk a little bit about the pre-field work phase there. So I definitely needed to organize for ethical approvals from Kenya and Ireland, and also obtain a research permit from Kenya, and this took a total of 6 months. And I also identified organizations. Wambui was very instrumental in helping me do this. So I worked very closely with the Alzheimer's and Dementia organization in Kenya, who helped me with participant recruitment, identification, and also in implementing the work. But I also gave talks in churches and community groups to talk about dementia because of the little understanding of dementia, but also to gauge how feasible what I was trying to do was, and also to gain the trust and support from these community members. So what were some of my experiences? So participant recruitment was really challenging. And I think this is due to the stigma that is attached to dementia, and also the belief that dementia is definitely just a part of the aging process. And also what I found is that some caregivers are really not conversant with the research, interviews or the research process. They didn't really understand why I was interested in talking to them. So I really took my time to explain how this study could potentially benefit them. But what I was really happy about was how caregivers seemed really at ease and how they spoke openly, providing vivid descriptions about their journey. Maybe this is due to the fact that I shared my own experience and with having a parent who has dementia. So most interviews were conducted in the presence of the person living with dementia, and and for me that was, I would have loved to do that a bit differently, because the person living with dementia was not included in a discussion which was about them. Again, thinking about involving people with dementia in conversations about them. But what I can say as well is that the interview was absolutely emotional, both for the caregiver and for me as a researcher. So just a few takeaways from that piece of work is really funding, funding. So in hindsight, when I look back, I think when I put in my funding application, I don't think I really targeted the right people. I also should have involved more experts in the field, in the project, and maybe also taken a little bit more time to develop a potentially winning proposal. But what I can say as well is that for anyone doing research in that context, so successful recruitment of participants is really contingent on identifying the key stakeholders in the communities. And also, and I know COVID probably will change how we do this, holding face-to-face meetings prior to the study to really, to connect with the communities, but also reimbursement for caregivers' time. And I found cash as opposed to non-cash benefits were better, because this allowed the caregivers to prioritize their own needs. But also having local emotional support systems built into the study for the researcher. And maybe my final suggestion is about future research. So I think future work needs to really explore the meanings attached to dementia in that context, in the different ethnic groups. I think we have over 40 ethnic groups in the country, And I think this information would be crucially important to inform the design of support and services for people living with dementia and their caregivers. But I think this information can also be very useful in contributing to the design of public health messages that would help raise awareness about dementia in that context. So that's really a quick one, but that's all I have to say for now. Thank you so much. And the other thing to say is that the results coming from this work have actually been accepted for publication, so that will be coming out very soon. So yeah, so thank you so much for having me.
Okay, so thanks, Purity. And again, the common themes of fear and stigma, I think that others have alluded, Fernando, mistrust, seems, some of these themes are similar worldwide and really have to be battled and tackled. So thank you very much. So I think that's the end of the formal presentation. So now we can actually move to questions, answers, and discussions. So if I just pull up the chat here, and let's see the questions and answers. Let's see, I have some questions for some of the speakers. So Stefania, there's a question here from Wambui. Do you believe it is essential for gender equity to be put in all national dementia policy campaigns? How would this look like when rolled out? What would be some practical examples for low and middle income countries? So you've got 3 questions there.
Yes, the short and long answer is yes, 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 absolutely yes. And particularly when we have to deal with the national dementia strategies that are about so much more than just prevention, not to underscore the importance of prevention, but gender is a crucial dimension. If we think about care, we know that, the overwhelming majority of care is provided by families and communities, primarily women, even care provided in formal settings where the workforce is overwhelmingly accounted for by women. So that we can't emphasize enough the gender dimension within the context of national dementia campaigns and strategies. But I just really want to get this point across that while gender is one crucial aspect, equity is about so much more. So I really don't want to give the impression that, all women are the same and they're different from all men. So this is really not the case. And in the graphs I showed, it was clear that higher income women, privileged women do so much better than men in poverty or in low socioeconomic status. So it's really about recognizing differences wherever they lie and figuring out ways to respond that are better targeted and that are most needed. For low and middle income countries, I would have to say this is not my strong point. My expertise lies primarily with European countries. So I don't want to speculate too much, but gender equity is clearly an issue there. Poverty remains a large issue, primarily for women. And the UN report on women that just came out this year emphasizes how important the COVID crisis was and how much it has represented a step back in terms of gender equity, particularly in low and middle income countries. So certainly these approaches are extremely, extremely important there.
Very interesting if you get your hands on some data from South America, Brazil, or even some African countries for comparison, wouldn't it?
Yes, if anyone has access to that, please do send tips my way. Yes. I would love to expand that type of analysis.
Lisa Gray has a question for you as well, Stefania. Could you give an example of how public health intervention has specifically sought to address the gender inequality factors? Is there any specific example? Maybe you could think about it and we could come back to it if there isn't one that pops into it.
Yes, I think here it's...
Yeah, go ahead if you want to go ahead, or I can come back to it, whichever you like.
Yeah, I think my connection is poor, but hoping that I heard all of that. So one example that comes to mind is, and again, focused on European countries, is the example of physical activity and health promotion interventions for physical activity that tended to have a lower take-up among women because they didn't address safety issues that women, and particularly older women, are concerned about. They didn't address the experience that women have in most places, or most organized settings for physical activity, whereas programs that targeted mothers and children were much more successful in drawing women to physical activities. So I think aspects like this, where we think of the design, but also of the targeting, in aspects such as cardiovascular health or diabetes, I'm aware that compliance with disease management and prevention programs is higher among women, but there are systematically groups of women that are never reached by these interventions. So there, maybe we can focus on targeting rather than design. But I think there's a lot we can do. And once again, I want to emphasize a lot we can do outside the health sector. So if we could do education and standard of living and poverty interventions, we would probably gain a lot.
Great. So just another question from Lisa Gray for Ieva about your arts and health program. How is it funded? She's talking about challenges in getting these programs funded in the UK. It's been funded by the NHS, but in Ireland, it's not clear where you get funding for it. So where did you get the funding for the program, your program, the museum program in Vilnius?
For the museum program, actually we use the cultural funds or external funds, like international funds. Even like I would say that for at least 10 years, it's spoken that there should be built new funding opportunities that respond to the aims related with health or access to arts, but actually for the moment they don't exist yet. There's much talk, and I think without much talk, we can't really build these type of fundings. But so the reality is that we use mostly cultural funds. But in terms of like the question was also how really access the funding that is related with health or health funding. There are projects where we act as partners. So in that case, where it is possible, but then you have actually it needs to build a partnership with a health partner and really build the trust and friendship and collegial mutual understanding, and seeing that the partnership is really mutual beneficial, and then provide, let's say, together, then you can address the needs that are already recognized by health funders. So then you can access the funding streams together. So these type of projects, they do exist, but it's very rare, and it really takes time to build these partnerships. But I do believe this is the future. But I just hope that there would be, funding resources would contributed from, let's say, Ministry of Health or Ministry of Culture. Yeah.
Great, thank you. So the question from Susanna Dooley for Clara. Interesting presentation. I'll just go down to the question here. She's curious to know if people with dementia have access to speech, language, and communication therapy in Galicia.
I would say very limited access. I mean, not in the public system unless you really, really, really push for that. It's normally, for example, speech therapy is normally addressed to stroke patients more than the neurodegenerative disease. And then in the private sector, I guess so. I'm not so informed about that, but yeah. So generally the answer is no.
There's a question here from, I think it's Emily Gill, about social prescribing. I think it's for you, Clara. Then it's, again, very much an area worth exploring. Again, with COVID, social isolation, increased referrals to old age mental health services. I wonder, she wonders about the blurring of roles between social prescribing and occupational therapy as OTs use similar skills that are proposed within the social prescribing model. So, not sure what your thoughts are on that.
Yeah, I already read the question before. I'm not sure if she means that, like, social prescribing will take the place of OTs or something like that. I see that, at least me, I see OT as a part of social prescribing, but not the only part. And actually, when you prescribe social treatment or send people to services, OT is a super important part of it that is not done by anyone else. But they don't do many other things. I mean, they don't do physical exercise programs. They sometimes don't do cognitive stimulation. I think they normally don't do that. They are more focused on adapting to the new reality and conditions, adapting the house, adapting the skills of the person. And I will include that on the social prescribing part. And I think that's one of the things that I'm super interested in giving more access to people, to occupational therapists, because I think it's basic. Yeah.
But I guess that a lot of occupational therapists are very much involved in post-diagnostic intervention. So, and I think your tool, you know, if it becomes available, is a complementary. I mean, it'll be a tool that could be used by doctors, nurses, OTs. It could be anybody, I guess.
For sure. What we want to do is to enhance collaboration, and for sure we will be super happy if an occupational therapy that has the time to, for example, drive the patient through the tool and learn how to use it and everything, that will be amazing. Yeah.
I'm going to finish now. I don't think there are any other questions that I've missed, but there's some very nice comments there from Francis Finn. I think this is to you, Fernando, but loves the term affection reserve. I'm not sure it's affection or affective reserve, but either one is excellent. And other comments saying just nice to see everybody. Maybe I should just wrap it up. I don't think I've missed any questions. Has anybody else spotted any other questions? If not, I just will draw the symposium to close, just to thank everybody. I think it's been a kind of a wonderful global tour. I think we've got really great perspectives. And I think, you know, you see the complementarity of everybody's presentations. You know, they seem diverse in one sense, but they are so connected in every other way. And I think that's the beauty of GBHI, I think, and the Atlantic Fellows for Equity and Brain Health, that everything is connected. We all stand together. And I think together we can make a big difference. So thanks to everybody, and thanks to the audience for tuning in. I think people have stuck with us over the hour and a half. And thank you so much for that. Thank you to Sinead and Ieva and Grace at Engaging Dementia. And thanks for inviting us to participate in this conference as part of this symposium. So goodbye, everybody.